Hi, this is Brian Kim. I'm going to share with you this case of a Bioniko cataract simulation case of a medical student. This is the Okulo BR8 model, and this is medical student number 2 who happens to be left-handed, and this is going to be her first attempt performing cataract surgery on a model eye. Bioniko was clear to tell me that this is not tissue stimulation cataract surgery, but more maneuver stimulation cataract surgery, which means, getting used to the different maneuvers within the incision and actually using forceps and instruments and phaco machine handpieces and choppers, etc., to be able to do cataract surgery. So in this case, the video got cut off, and so she's already made the cystotome puncture, and now she's grasped and created a flap. You can see she's going clockwise here. And again, as far as the tissue simulation, it's not really quite like tissue because the flap wants to go back flat again. It's really stiff, and natural human capsule doesn't quite do that. It lays where it was left. And of course, there's a little bit of a challenge then having to re-grab when the flap goes back down. And so again, she's left-handed, as you can see. She's doing the best she can to try to grab that flap. She finally got it. And now she's, again, directing her forces down towards the incision. And she's going to have to try to make that turn. She's turning her hand a little bit. She's supinating a little bit. And then she's getting it around. Rexus a little bit on the small side, but not too bad. She was able to turn that corner real nicely, grasping the flap again before it could fall back down. And you can see she's going around the best she can. And again, she's redirecting the forces, which is a really great maneuver right there. And pulling again away as she is here. So again, I think she did a really, really good job. Again, for the first time doing a capsulotomy, she was able to have a good understanding of the vector forces and creating that rexus. Again, I think that's the purpose of this simulation. Again, it's really a maneuver simulation and not a tissue simulation, again, stated by Bioniko. And so now you can see her, she finishes off the rexus. And that was very good. And so now she's going to use a blunt tip cannula to try to hydrodissect. She gets the cannula under the rexus edge as far as she can, and then she starts pushing BSS. We did not really see a fluid wave as she did this, and she's going around picking different places to get that wave. But again, I didn't really appreciate much of a wave as she did this maneuver. You will see in a future case where I'm actually doing the cataract surgery myself, and I'll be able to share with you my first-hand experience with this particular model. You can see she's got a nice rexus opening. You had, again, she made those incisions as well. And using the ink pen to mark the limbus, I think, is quite helpful with this model. By doing it this way, you have a much better understanding where your incision is. Of course, in a real human, when you make incisions, you can see a little bit of heme. You can see a little bit of change in the wound there. Of course, you don't have that with an artificial eye, and so marking it with the ink pen is quite helpful. And so now she's beveled up and she's starting to sculpt a trough. I've been telling her about the anatomy of the lens and how it is more convex on the front end and more concave on the back end. And that means it's deeper in the middle and less deep on the sides. So she really needs to groove deeper in the middle, but she can't stay in the same plane as she goes out towards the limbus. If she does, she'll encounter the posterior capsule and have a hole and have a complication. So I'm trying to encourage her to sculpt deep, but then as she goes more peripheral from the center, she needs to actually sculpt higher, closer to her, which means she's going to be away from the posterior capsule and less likely to hit the posterior capsule while she's sculpting. And you can see here she's trying to crack. She has a Maltzman instrument here, which is really, unfortunately, the only instrument we had while we did this. We were doing this late in the evening at the operating room by ourselves, along with the other medical student. And so, this instrument is actually pretty good, the Maltzman, for spinning a free lens. Not quite sure it's really ideal for cracking. But like I said, in general, as Bioniko would tell me, this is not tissue simulation, this is really maneuver simulation. So the lens itself, although looks like a cataract, it's not quite the same as the true human cataract. And so she's doing the best she can to grab these small pieces, but as you can tell, she's having a little bit of trouble here. She's using some vacuum to try to grab some of those pieces out in the periphery. And of course, I'm explaining to her the balance between using aspiration and vacuum versus using ultrasonic energy. It is important for her to understand that she can apply aspiration vacuum out there in the corners, but would be very mindful and wary of applying ultrasonic energy when she's got the phaco probe so close to the posterior capsule. And so she's heeding my advice, and she's been very careful and just aspirating and also doing vacuum when she's out beyond the central safe zone, trying to grab those pieces, again, mainly because they're not mobile. And we don't have the actual head model for this exercise. And so what we had to do was we grabbed a large garbage bag, placed it over the headrest, taped the garbage bag and a plate mount with the eye here because there's a suction mount, and we taped it with surgical tape. And so it keeps that garbage bag open and allows the fluid to come out without making a big mess all over the floor. And so a little bit cumbersome. Again, the folks at Bioniko told me that's why you need to have that head model. Of course, we didn't have that access to that. And so we did the best we could, and it still was fine, but it was just a little bit cumbersome having to deal with the fluid. You can see here she was pretty good about turning the bevel towards the left. So that's another pearl. If you're trying to get purchase and you try to grab pieces, you want to turn the bevel towards where you're trying to get purchase. And so if the piece is on the right side, you can turn the bevel towards right, so you can kind of get good suction and purchase of the lens piece, which you can then increase vacuum and then pull the pieces out. If it's on the left side, it's the same thing. You want to turn the bevel to the left. So again, you can see she's primarily using aspiration and vacuum to grab those pieces out of the bag. It's essentially just kind of locked into place. But again, very, very carefully, she's trying to grab those pieces little by little. Again, hard to simulate sculpting with this case, and again, difficult to allow the lens to spin freely within the bag. Again, that would certainly be more of a tissue simulation. Again, this is really more of maneuver simulation, learning how to manipulate your instruments within the incision. I think that's very important for surgeons to know how to pivot the instruments within the incision rather than trying to move translationally. A lot of people who are learning, they want to move their instruments translationally and forgetting that they're going to be trapped by the incision. So if you move your instruments translationally, what happens? You're going to move the eye in all different directions, and you'll find yourself moving the eye off the screen when you're doing surgery. That's a telltale sign that you're having translational movement within the incision because you're pushing on the incision and the eye is moving off screen. But if you learn to position and pivot your instruments within the incision, then essentially you shouldn't be putting any traction on the incision. You're able to very confidently manipulate the instruments and turning the instruments to give yourself better access to the lens pieces so you can disassemble the lens, and you're utilizing ultrasonic energy vacuum, whatever it may be. But again, you're pivoting within the incision rather than trying to push the instruments whichever way you want to without consideration of the incision. So you can see here, she's trying to grab that piece. She's trying to get purchase of it and then grabbing it up. And again, not so easy, but the lens is just kind of crumbling as she's chipping away at these pieces. And she's patiently teasing off these pieces one by one. So essentially, she's removed the lens pieces, about half of it contra-incisionally. She still has some sub-incisional lens pieces. And again, using aspiration and vacuum, she's chipping away at these lens pieces, and she's being very mindful of not getting that phaco tip near the posterior capsule. And now she's got a pretty big piece sub-incisionally, and she's trying to figure out how she's going to get to those pieces. Of course, the best thing to do in this case is, if you can hydrodissect once again. But of course, in this case, it's not really a real eye. It might not work. So then you can use your second instrument to try to pull the pieces up out of the bag. And so that's one thing that I would consider doing. But again, that's kind of a higher level technique. She's being very methodical in using the phaco tip and leveraging the aspiration and vacuum so that she can grab those pieces even though they're sub-incisional. And again, she's using the Maltzman to very carefully tease those pieces up out of the bag. And I think she's actually doing quite well using both hands to very controllably manipulate those pieces out of the bag and then aspirating them and emulsifying them with the phaco tip. And what's nice about this is you can use this on any phaco machine. What we used here was the AMO Compact, and you have to hang the BSS bottles with that machine. And so I just cut a small hole in the top of the bag, and we just kept filling it up with water instead of having to use our precious and quite costly BSS. And so we were just using tap water and pushing it and refilling the bag each time. Here she ran out of some water here, so we're having to change out the bag. And again, really, this is a fairly low-cost way of learning how to do cataract surgery on an artificial eye. So now that we've changed the bag, she's starting again. You see that, oh, there's a lot of bubbles. And that's because we had to switch out the bag. She's using the Maltzman to tease up that sub-incisional lens piece. I think that's excellent technique. And she loosened that sub-incisional lens piece up. And then she's able to grab it with the phaco handpiece and then emulsify the lens piece. And so that's it. That's the end of the case. She's removed all the lens. She's got a nice continuous curvilinear capsulorhexis. And again, I do feel like this is excellent maneuver simulation versus a tissue simulation. It does teach how to place your incisions, how to manipulate your instruments within the incision without overlocking yourself, without moving the eye too forcefully, and then performing capsulorhexis, and again, performing phaco, understanding how deep to groove, where to groove, and then you're leveraging the phaco machine and using aspiration vacuum, grabbing purchase to grab the lens pieces up out of the bag. So I feel like this was a very good exercise. And again, like I said, my medical students were very grateful for the opportunity and felt a lot more confident that perhaps, this is something that they can do. The problem with training is students have no idea if they're fully capable of doing intraocular surgery. And the most tragic thing would be a person who's really motivated to do ophthalmology, and they get into a really competitive residency, and then they actually start doing cases and they realize they're just not capable of executing a safe surgery. And so, what do? You give up on your career, Of course, then you have to think about maybe doing some other specialty that's not intraocular surgery, which is, again, not the end of the world, but it certainly would be nice to have a mechanism to really gauge if you're capable of doing intraocular surgery. Again, this is a far cry from real surgery, but nonetheless, it gives some people an idea of seeing through the microscope, understanding depth of field, depth of vision, and how deep to go when you're sculpting, etc. And all of those things are vitally important when you're doing cataract surgery. And I felt like this was invaluable teaching for medical students. And hopefully this is something that you could utilize if you're considering ophthalmology as a medical student, or if you're a resident and you're wanting to practice additional maneuvers before you get into actually operating on real patients. This is something that could be helpful to you. So again, I hope this was helpful to you, and I thank you for your attention.